Hello guys, good evening. Hi, how are you? And I hope that your day was good. Okay, we'll start with a new fresh topic in why conundrum, why carbamazepine cannot be used in emergencies. So here we are talking about carbamazepine. As we know, carbamazepine is an anti-epileptic drug. I hope you would be knowing it. Even if you don't know, don't worry. We are here to explain that to you. So carbamazepine is an anti-epileptic drug. It is not used in terms of emergencies. And why is that? That was the question. Emergencies means in terms of emergency, what to say, any types of epilepsies or in terms of acute episodes, you cannot administer carbamazepine. The reason is, the reason is, we were talking about why is it not administered in emergencies, because carbamazepine. Okay. So because carbamazepine is a drug which is always administered by low doses, but it follows a technique called as SLGS technique. SLGS technique stands for start low and go slow technique. A very famous technique how we have to start the doses of carbamazepine in patients who are landing up in epilepsy. Especially we are currently using carbamazepine for partial seizures and also for trigeminal neuralgia. So we follow a technique called as SLGS, start low, go slow technique, which means we have to start at extremely low doses and the escalations has to be very much gradual. It shouldn't be up to the maximum. Again, coming back to this, why do we start at low doses? Why do we need to start at low doses? Again, before that, you would have easily understood if we are starting the drug at low doses, can it be used in terms of like emergencies, guys? We cannot use it in terms of emergencies. So if we are using it in terms of emergencies, we have to make sure the drug is producing maximal response in the patient. So we have to start at high doses or any therapeutic doses. But here we don't even administer therapeutic doses, we administer sub-therapeutic doses. Why is that? Why? Because this carbamazepine is associated with severe skin reactions named as Stevens-Johnson syndrome. This is associated with severe skin reaction named as Stevens-Johnson syndrome. We'll proceed on further. To prevent this adverse effects from happening, always we started with low doses. But again, why some patients are developing this Stevens-Johnson syndrome to carbamazepine? Not all the patients, guys, not all the patients, only some patients will be developing this. So here comes the next question, why some patients are developing this Stevens-Johnson syndrome? The answer for this question would be some patients who are positive for HLA-B 1502 allele. Some patients who are positive for HLA-B 1502, they will be more prone to land up in carbamazepine-induced Stevens-Johnson syndrome. Again, the question comes, why HLA-B 1502 allele positive? It is not positive for all the patients, only for some. But why those patients are landing up in positive? And if they are landing up in positive, why they are landing up in carbamazepine adverse effects? So again, why is there a relationship between HLA-B 1502 and carbamazepine? The point here is, this HLA-B 1502 allele will be having a high affinity with carbamazepine. What happens? Whenever this carbamazepine and HLA-B 1502 allele or HLA molecules which are present, if it is getting joined back together, that is going to be stimulating the T cells. It will stimulate T cells, which in turn will be targeting your keratinocytes. These T cells will go affect your keratinocytes. Because these molecules are going and affecting the keratinocytes or the skin cells, patients will land up in Stevens-Johnson syndrome. Is that clear, buddy? So what's the question here? This HLA-B 1502 allele, if it is fusing up with carbamazepine, that will stimulate the T cells, thereby it might affect the keratinocytes leading on to Stevens-Johnson syndrome. And which patients are at more risk? Patients who are positive for HLA-B 1502. And the next step, what might be the adverse effects to be expected? Stevens-Johnson syndrome. And how do we prevent that from occurring? We start the patient at low doses and we slowly escalate the drug dose. We will not abruptly or double the drug dose. We will slowly escalate the drug dose. So what is the clinical implication of it? That's the reason why we cannot use carbamazepine in terms of emergencies. Because in terms of emergencies, I can't administer low dose and see what's the responses. What if you administer high dose and the patient lands up in allergic reactions or Stevens-Johnson syndrome? That is going to be backfiring for the patient and also for the doctor. Well, that's the reason for it. We'll just dig in a little bit deeper. Which other drugs cannot be administered if the patient is positive for HLA-B 1502? If a patient is positive for HLA-B 15021 allele, which other drugs should not be administered? We have phenytoin, we have carbamazepine, and we have lamotrigine. HLA-B 150 positive, we cannot administer phenytoin, carbamazepine, or lamotrigine because all these three drugs are associated with allergic reactions, or simply it might leading on to damage to the keratinocytes, which may further progress on to a severe form of Stevens-Johnson syndrome, or it may also further progress to TEN, toxic epidermal necrolysis. Stevens-Johnson syndrome and toxic epidermal necrolysis might be expected with some patients who are under phenytoin, carbamazepine, or lamotrigine therapy, and also testing positive for HLA-B 150. That's it, guys. That's it for today's Y Conundrum. We'll meet up in one more Y Conundrum very much shortly. Good night. Bye-bye.